That last fairy tale sketch was pretty disturbing, to say the least. I had my eyes closed for most of it, but I do remember a few buzzwords. Gliptins, exenatide, glipizide, the glinides. It was all about boosting that endogenous anabolic hormone, insulin. In our next scene, we're just going to let that insulin do its thing, while we focus instead on drugs that lower glucose levels by their actions on liver, muscle, and adipose tissue, drugs that affect absorption of glucose in the GI tract, and drugs that prevent reabsorption of glucose from the kidney. Wait a minute, surging blood sugar, raging hormones? That can only mean one thing. It's Valentine's Day! First, take a look at the sign hanging in the back of the classroom. You remember second grade, right? Your first crush, the first time you were shot down by your first crush, your first rebound crush. Well, we're not here to uncover painful childhood events. Second grade is supposed to remind you of type 2 diabetes. Remember, type 1 diabetes usually results from autoimmune destruction of the insulin-producing beta cells in the islets of Langerhans. So you need to give them insulin exogenously. Type 2 diabetes, on the other hand, is usually characterized by insulin resistance. In other words, in early stages of the disease, your pancreas can make its own insulin. Your body is just resistant to it. As type 2 diabetes progresses, beta cells start to fail, and many patients will also be on an exogenous insulin regimen. However, while there are still functional pancreatic beta cells around, there are a few ways we can help them out. In our last scene, we gave them a boost and upregulated endogenous insulin production. In this sketch, we're going to let those tired beta cells relax and focus on other organs outside the pancreas that can help bring that serum glucose under control. Let's start at the liver, one of the main sites of action of metformin, the first-line oral agent for the management of type 2 diabetes. And since it's Valentine's Day and love is in the air, this kid in the back here has decided to finally proclaim his adolescent infatuations in the form of a sonnet. My love is a flame. Nice. Let this metaphor remind you that he embodies all that is metformin. Metformin is a beguinide, an oral agent used to decrease serum glucose by a few poorly understood mechanisms. Metformin decreases hepatic glucose production, decreases intestinal glucose absorption, and increases peripheral glucose uptake and utilization. Metformin's major effect is to decrease hepatic glucose output by inhibiting gluconeogenesis. See this girl here, the target of our love-struck students' awkward attempts at iambic pentameter? As she pulls candy out of this liver-shaped bag, let it evoke an image of hepatic glucose output, or gluconeogenesis. Well, metformin suppresses gluconeogenesis by modulating the function of enzymes. Specifically, it inhibits a mitochondrial enzyme called glycerophosphate dehydrogenase, an enzyme responsible for getting molecules into the gluconeogenesis pathway. So let this bite out of a mitochondrial candy remind you of metformin's ability to inhibit mitochondrial enzymes. Metformin also activates another enzyme called AMPK, which also contributes to the reduction in hepatic glucose output. Gluconeogenesis coming to a halt is depicted by this other girl here, putting a hold on the liver candy consumption in order to draw her friend's attention to the uncomfortable situation unfolding behind her. See that AMPK label? Again, the main theme here is that metformin works by modulating the function of enzymes. Alright, besides suppressing gluconeogenesis, metformin also helps patients attain glycemic control by facilitating the peripheral uptake of glucose. Think of it as increasing your body's sensitivity to the insulin you're already making. Insulin is the storage and anabolic hormone of the body, and at Sketchy, we usually represent insulin with a welcome inside mat. In this sketch, we've incorporated the same idea into a little Valentine's mailbox on this student's desk, inviting classmates to place those sugary Valentine's treats inside. Just think of insulin as the hormone that welcomes glucose and fat inside of cells. So metformin is able to reduce serum glucose levels by enhancing insulin-mediated glucose utilization in peripheral tissues, such as muscle and liver. Okay, a few side effects to keep in mind. First of all, metformin therapy in type 2 diabetes can lead to lactic acidosis. This spoiled milk here being spilled by our awkward suitor is our recurring sketchy symbol for lactic acidosis. This is not going well for him. It turns out that when you inhibit hepatic gluconeogenesis, you also restrict lactate's ability to enter gluconeogenic pathways in the liver, so it builds up in the serum. Though rare, lactic acidosis can be fatal and is more likely to occur in conditions of tissue hypoxia, when there is already increased production of lactic acid, and in renal failure when there's decreased clearance of metformin. You see, metformin is not metabolized and is just excreted by the kidneys as an active drug. In patients with renal insufficiency, metformin accumulates and therefore increases the risk of lactic acidosis. This is depicted by the lunch tray, which looks oddly kidney-shaped, and all those little cracks in it should evoke the image of kidney disease. So as the sour milk spills from the tray, just remember that lactic acidosis is more common in the setting of renal insufficiency. In fact, for most patients, if your creatinine is above 1.4 to 1.5, metformin use is not recommended. The most common toxic effects of metformin are GI-related. This includes anorexia, nausea, vomiting, and diarrhea. So as a conclusive sign that this courtship has suffered a humiliating and premature end, his would-be Valentine is overcome with nausea at the sight of that spoiled milk. I think she just vomited in her mouth a little. Well, it turns out that metformin does not increase body weight or provoke hypoglycemia, which gives it an advantage over insulin and other sulfonylurea agents from the previous sketch. In those who are obese, metformin actually promotes modest weight reduction, or at least weight stabilization, hence Romeo's thin physique. Alright, on to our next family of oral anti-diabetic agents, the thiazolidinediones, including rosiglitazone and pioglitazone. Just think of the glitazone glitter here that's flying out of this card onto his pleasantly surprised sweetheart. Now that's how you ask someone to be your Valentine. These oral agents work by increasing glucose utilization and decreasing glucose production in adipose tissue, muscle, and the liver. Again, just think of these agents as exerting their glucose-lowering effects by increasing your body's sensitivity to insulin. Pioglitazone and rosiglitazone are ligands of peroxisome proliferator activated receptor gamma, or PPAR gamma, part of the steroid and thyroid superfamily of nuclear receptors. And as you can tell by his self-assured demeanor, this guy knows how to PPARY, if you know what I mean. Notice that we've put the PPAR gamma inside of a circle to emphasize that this is an intracellular nuclear receptor we're activating here. These PPAR receptors are found in muscle, fat, and the liver, where they control the expression of all kinds of genes, including those involved in lipid and glucose metabolism, insulin signal transduction, and adipocyte differentiation. One of the most important genes regulated by PPAR gamma is one that encodes for adiponectin, a cytokine secreted by fat tissue that enhances insulin sensitivity and fatty acid oxidation. Hence, he wears that stylish adiponectin turtleneck. Never goes out of style. Adiponectin levels are low in obese patients and those with type 2 diabetes, so treatment with pioglitazone or rosiglitazone gives you that extra bump and improves insulin sensitivity. It turns out that activation of PPAR gamma also leads to an increase in fat mass, secondary to increased differentiation of pre-adipocytes into mature adipocytes. And that's why he holds up our recurring symbol for adipocytes, that big donut jar, like a big fat cell storing some fatty triglyceride donuts. The thing to keep in mind is that this is triglyceride storage we're talking about here. Think of gobbling up all your triglycerides and packing them away into all those mature fat cells. The thiazolidinediones cause increased movement of free fatty acids into fat cells, along with increased fatty acid oxidation, so this causes circulating triglyceride levels to decrease. Activation of PPAR gamma also leads to the upregulation of genes that code for glucose transporter 4, or GLUT4. GLUT4 is the insulin-responsive transmembrane glucose transporter, expressed in adipocytes and skeletal muscle. It's responsible for increasing glucose uptake by target cells. In fact, it's the same glucose transporter incorporated into the door of that creepy insulin cottage from the previous sketch. So, in effect, the thiazolidinediones help patients attain glycemic control by facilitating the peripheral uptake of glucose. Just like with metformin, think of it as increasing your body's sensitivity to the insulin you're already making. Again, because we usually represent insulin with a welcome inside mat, we've got another little Valentine's mailbox on this student's desk, inviting classmates to place those sugary Valentine's treats inside. Just think of insulin as the hormone that welcomes your glucose and fat inside of cells. Remember, however, because the glucose-lowering effect of thiazolidinediones requires an alteration in gene transcription and protein synthesis, a meaningful reduction in glucose levels takes days to weeks after commencing therapy. Alright, keep in mind that because pioglitazone and rosiglitazone promote increased fat storage into adipocytes and an increased number of adipocytes, they can cause an increase in fat mass. Just remember that the glitazones put extra glit in your zone. This weight gain may be especially prominent when the glitazone agents are taken in combo with a sulfonylurea agent, or insulin. Think back to that hefty witch lazing around next to the sulfonylurea swan. Okay, the main side effect of the thiazolidinediones is fluid retention due to increased sodium reabsorption in the renal collecting tubules. This can lead to fluid retention, peripheral edema, and decompensation of underlying congestive heart failure. Peripheral edema is highlighted by his edematous, baggy sweatpants. What a ladies' man. Also, take a look under the leg of his chair. It's our recurring symbol for heart failure. The sad, floppy heart balloon. This time getting crushed by our gluttonous and decidedly hefty second grader. Just remember that the fluid retention caused by the thiazolidinediones can exacerbate heart failure. In fact, these agents are contraindicated in the later stages of heart disease. Pioglitazone and rosiglitazone can also cause a loss of bone mineral density and an increase in fractures in women, possibly due to decreased osteoblast formation. Whatever the cause, we've got some definite fractures occurring here as this overly confident, portly pupil leans back on that chair for the last time. Okay, let's move over to the other side of the classroom where we'll cover a few more agents used for glycemic control in the setting of diabetes. First up, pramlintide, an analog of islet amyloid polypeptide, or amylin. Amylin is present in insulin. Wait, no, he didn't. I see what happened here. He asked two girls to be his special Valentine, and twins no less? Well, of course they're gonna find out. Come on, Brayden, you're better than that. Amy and Lynn represent amylin, of course, a peptide normally present in insulin secretory granules and secreted along with insulin. At pharmacologic doses, it reduces glucagon secretion, slows gastric emptying, and centrally decreases appetite. Decreased gastric emptying is depicted by our Valentine's hustler over here leaning against this stomach-shaped water cooler in complete surprise, as the amylin twins call him out on this disgraceful Valentine's Day behavior. At Sketchy, glucagon is represented by sweetener packets, because glucagon is responsible for gluconeogenesis, glycogenolysis, processes that normally increase your blood sugar. Well, pramlintide works to suppress glucagon, depicted by these spent glucagon packets littered behind our fickle friend here as he searches for the nearest emergency exit. See how Amy and Lynn hold up 1 and 2 fingers respectively? Pramlintide can be used to manage hyperglycemia in either type 1 or type 2 diabetes. In both type 1 and type 2 diabetes, pramlintide can be used to control that postprandial spike in glucose concentration, especially in the setting of a high-carbohydrate meal, such as this cupcake over here with a prandial bite already taken out of it. Let me guess, Brayden. These cupcakes were for Amy or Lynn, whoever answered your letter first. You disgust me. Pramlintide is injected subcutaneously, immediately before eating. The most common adverse effects include hypoglycemia and GI symptoms, including nausea, vomiting, and anorexia. Hypoglycemia is illustrated here as Amy shows Brayden what's about to happen to his face. And those GI symptoms are illustrated by Brayden here as he suddenly gets sick to his stomach, imagining what's about to happen to said face. Okay, this is getting a little ugly. Let's calm down with some sugar-free snacks. Okay, they're slightly childproof, just gotta pull it chip bag style. You know what, sugar-free gummy worms weren't really my thing anyways. See the box down there? That's A-carb for acarbose. And the Wigglers? That's miglitol, of course. Both are alpha-glucosidase inhibitors. That means that they competitively inhibit the intestinal alpha-glucosidase enzymes normally responsible for turning disaccharides into absorbable monosaccharides. Hence the monosaccharide-free fine print on the acarbose box. Specifically, acarbose and miglitol reduce the activity of disaccaridases on the intestinal brush border. And no Valentine's Day bash would be complete without some festive brush border themed flags. Because carbohydrates are normally absorbed as monosaccharides, the inhibition of disaccharide breakdown by these agents delays carbohydrate absorption. Just think of our friend over here suffering some delayed access to his favorite Wigglers as he struggles with the childproof packaging. Decreased postprandial glucose absorption means that the alpha-glucosidase inhibitors can be used to blunt that postprandial rise in serum glucose. Again, we've included a postprandial cupcake. I guess he couldn't wait. These agents can be administered at regular intervals throughout the day, with potent effects during that mealtime carb load, lowering postprandial glucose levels by 30 to 50%. These drugs are infrequently prescribed, however, because of their prominent GI side effects. This includes diarrhea, flatulence, and abdominal pain as a result of all that undigested carbohydrate sent to the colon, where it's fermented into short-chain fatty acids and a ton of gas. Yep, that restroom is going to be occupied for a while. Too many Wigglers. I warned him. Alright, on to our last class of oral agents used for glycemic control in the setting of type 2 diabetes. The SGLT2 inhibitors. The SGLT2 inhibitors include canagliflozin and dapagliflozin, drugs that have that flozin suffix, highlighted here by our flossin second grade teacher, trying to make a good first impression with the attractive new substitute teacher who's about to walk in his direction. Canagliflozin and the rest of the flozins are a new class of oral antidiabetic agents known as sodium glucose cotransporter 2 or SGLT2 inhibitors. SGLT2 is a low-affinity, high-capacity transporter protein that is responsible for reabsorbing 90% of filtered glucose in the proximal tubule. SGLT2 inhibition leads to significant urinary glucose loss. Just think of flossing away and excreting the sodium and glucose normally co-transported in that salty and sugary kettle corn snack. To remind you that this inhibited sodium glucose transport is occurring in the proximal tubule, we're bringing back our recurring theme, the proximal convoluted tubule procart tract. This time incorporated into an inspirational poster in the back of the classroom. Race for your dreams. So moving. SGLT2 inhibitors are second or third line drugs that are generally added to an existing oral antidiabetic medication regimen. It's usually an alternative to insulin therapy in patients with type 2 diabetes who fail to achieve their glycemic goals. Side effects from the SGLT2 inhibitors result from keeping all that sugar in the urine. This includes UTI, symbolized as usual by our recurring ureter and bladder-evoking beverages. Ooh, looks like the attractive new substitute teacher is about to make her own moves. Ooh, uh-oh. In comes one of the second graders to interrupt this blossoming workplace passion with our recurring symbol for vaginal candida infection, the old Canadian snowball to the crotch. Typical Canadian antics. You see, all this glucose in the urine can lead to genital and urinary tract mycotic infections, including yeast infection. The increased osmotic diuresis induced by the SGLT2 inhibitors can also cause symptomatic hypotension in some patients, particularly the elderly and individuals on diuretics. So we've got another Canadian prankster over here getting a little hypotensive as he diureses his pants in laughter. SGLT2 inhibitors should be avoided in patients with moderate to severe renal impairment, due to lack of efficacy and increased risk of adverse effects. So again, the lunch trays are looking a little worse for wear, evoking the image of renal insufficiency. Renal function should be assessed before initiating SGLT2 inhibitors and periodically thereafter. Alright, that's it. It's time to sum up this whole Valentine's Day bash. We're in the 2nd grade because most of these agents are used to treat type 2 diabetes. All that means is your patient will most likely have some beta cell function left and can still produce insulin endogenously. These agents help sensitize your body to this remaining insulin, or they can act in other ways to lower the glucose load in your body. Metformin, represented by that heartfelt metaphor, is the first-line oral agent for glycemic control in type 2 diabetes. Metformin modulates enzyme activity to decrease hepatic gluconeogenesis, just like the rudely interrupted hepatic glucose output from that liver-shaped candy bag. Metformin also facilitates the peripheral uptake of glucose. Think of it as increasing your body's sensitivity to insulin, as some classmates place those sugary V-Day treats inside that mailbox. Metformin can lead to lactic acidosis, especially in the setting of renal insufficiency. Metformin also promotes modest weight reduction, hence our suitor's thin physique. In the back, we've got the thiazolidinediones, including rosiglitazone and pioglitazone. Just to think of the glitazone glitter. They activate PPAR-gamma inside the nucleus to upregulate genes involved in lipid and glucose metabolism. This results in an upregulated adiponectin turtleneck, increased mature adipocytes, and more GLUT4 transporters, getting more glucose into cells like candy into that mailbox. Again, just think of it as increasing your body's sensitivity to insulin. Keep in mind that these agents can put extra GLIT in your zone and cause weight gain, and also can lead to fluid retention exacerbating heart failure. Amy and Lynn represent the amylin analog pramlintide. It decreases gastric emptying, suppresses glucagon, and can be used to control that postprandial spike in glucose from that sugary cupcake. Over at the Wigglers, that's our miglatol and acarbose. They inhibit intestinal alpha-glucosidase so that disaccharides can't be converted to the absorbable monosaccharides, thereby delaying carbohydrate absorption. Specifically, they're used to decrease postprandial glucose levels, so again, keep that postprandial cupcake in mind. These drugs are infrequently prescribed due to the prominent GI side effects, leaking under the bathroom door. And our last agents are the SGLT2 inhibitors. SGLT2 usually co-transports sodium and glucose into the proximal tubule. SGLT2 inhibitors, then, are like this canagliflozin floss, helping you floss away those salty, sugary kettle corn bits. Watch out, though. All that glucose left in the urine can lead to UTI and other wacky Canadian antics. Well, that about sums it up, don't you think? You know, I thought love was in the air. Love was in the air. But, you know, it turns out it was just disappointment and regret. And wigglers. And wigglers. And wigglers.